Now, of course, as I've mentioned on a couple of occasions here, stopping suicidal behaviors is an important component of the treatment working. And so for that reason, I'm also going to be attending to things that we may do in working with suicidal individuals in other treatments as well. One of which is we're going to want to work on developing a safety plan. And so early on in session or in therapy, what I'm going to also work on doing is coming up with a list of other things she might do when she finds herself struggling with suicidal urges. That can include, of course, providing her with applicable crisis line numbers. That can include providing her with the contacts for other professionals that she can reach out to, myself included. That can include getting her to engage in other distracting activities. Maybe that includes who are other safe people that she might reach out to. Not just to talk about her distress, but to talk about other things as a distractor from her distress. What are places that she can go where she can be around other people? It's a lot harder to engage in these behaviors when you're in the presence of others. We're going to be looking out for helping her come up with a list of distracting activities that she can use to just make it a little easier to get through those moments till we're better able to work on addressing the problem that's setting off the suicidal thinking in the first place, which for her is a great deal of sadness about things that she's not currently having in her life. There's a variety of different forms out there in terms of completing a safety plan. Main things that we're looking out for is making sure that you're providing her with applicable contacts in terms of who are professionals, crisis lines that she might reach out to. And again, that's going to vary depending on the region that you're in. Number two, who are other safe others that she might reach out to talk about, to be around. And sometimes this can include to talk about things unrelated to her distress as a distractor, as getting her engaged in something else. We're looking out for other distracting activities that she can do, including often getting out of the house and away from what it is that she might use to engage in suicidal behaviors. And then, as I mentioned before, in DBT, I'm also giving my client my number so that they can reach out to me if they're struggling in or needing assistance in being able to manage certain suicidal urges or such. Now, it's not meant as a substitute for a crisis line. I'm going to be giving that as well, but it's there for skills coaching in the sense that what I'm going to be doing is seeking to provide support to my client when they're trying to apply skills and having a hard time doing so. Again, I imagine some of you might be thinking, oh my gosh, I don't know about giving my client my number. And of course, I would encourage you to talk with your peers. There's different requirements that may occur or arise depending upon the program at hand, but it is essential, one of the ingredients in DBT. So we've talked a little bit about a safety plan. The other thing that we're recognized as one of the most important interventions in reducing suicidal behaviors is to remove access to means. And so this is why one of the other reasons I'm going to be asking about suicide and past suicide attempts is to get an understanding about, do they currently have access to means? And if that's the case, we're going to work on removing those. What does that look like? If I've got a client, for instance, that has a rope that they were using as a method of suicide, we're going to want to work on having them get rid of that. It could be throwing that in the garbage. It could be giving that to a loved one who's able to remove it. And I'm, of course, going to generally want to get some kind of confirmation that's happening as well. Sometimes it's just putting further distance between them and the means when they're not always willing to get rid of it. Let's say you have a client, for instance, who has a weapon that's valuable to them and they're not willing to get rid of. Can they give that to somebody else for a while? Can they put that in a locker and give the key to somebody else for a while? One of the other things that I found is quite handy with clients that are at risk of overdosing on medication is working with the pharmacy, in the sense that I notice what often happens is our pharmacies, at least here, are willing to provide the client with only a couple of days of prescription at a time so that they're not actually having a lethal dose around. So again, these are the kinds of things that we're going to want to be paying attention to, because one of the most effective things we can do in trying to prevent suicidal behaviors, particularly in the short term, is do what we can to help remove access to means. So we've talked again about the targeting hierarchy. We've talked about useful instruments. We've talked about the problem-solving model for managing suicidal behaviors. And now we've also talked a little bit about safety planning and removing access to means. Now from here, of course, one of the other things I might do is I might be working on trying to get a commitment from the client for no suicide or to the treatment. And if you think about it, committing to doing the treatment entails staying alive. Now, you might ask, why do we do that? And really, the primary reason for doing this is social research has shown that is when we make verbal commitments to other people and or actually out loud commitments to ourselves at times, we're more likely to follow through with those behaviors. And so this is one of the reasons why I'm also going to be asking Sophia for a commitment. And it might look something like, so we've talked about the treatment. It sounds like we're both on board with doing it. And so there's one thing that's necessary in order for this treatment to work. And that is, I need you to stay alive. And so is that something that you're willing to do? Is that something that you can commit to with me right now? There's a variety of different DBT strategies for building commitment. There's what we call the foot in the door. This is where we start out small, and then I'm working my way up from there. It could be, for instance, me asking Sophia, hey, I'm wondering if you would be willing to take suicide off the table, perhaps for the length of treatment. Yeah, John, I guess I can give you that. Fantastic. Now, do you realize that actually the studies looking at the treatment have found that people's skills use continues to increase even after completing the treatment? They've done, for instance, a year follow-up study, and they find that their skills use continues to increase even after having done that. So really, if we're going to be giving the treatment a full try, that would mean that you are committing to no suicide for the next 2 years. Is that something you're willing to do? So I'm starting out a little bit smaller, and then I'm working my way up from there. There's other clients who I might be working with who I'm thinking, you know what, they're not likely to give me a big commitment, and so I might start out big. This is called the door in the face technique in DBT. And that is, all right, I recognize you've been struggling with suicidality for quite a while, and I think in order for you to build a better life, you need to stay alive. And so are you willing to commit to not killing yourself for the rest of your life? Heck no, John, I'm not willing to do that. And from there, we might whittle it down a little bit. Again, sometimes by starting big and whittling it down, you're more likely to get a commitment from a client as well. And so again, this is a dance, different techniques. There's others out there, depending on what it is that's going on. But what we know is that by asking for a commitment, it can increase the likelihood of somebody following through with it. Of course, it's not a guarantee. This is very different from a no suicide contract. That's, again, not generally something we're doing. What we are doing is we're developing pretty thorough safety plans, and we will be asking at times for verbal commitments, or often. The final thing, of course, that we're going to be doing with those commitments is we're going to be troubleshooting those commitments. It would be naive to think that somebody that's struggling with suicidal urges isn't going to have them again. And so what we're also going to be looking out for is, of course, planning for what they do when those suicidal urges reemerge.